Have you ever felt that sinking feeling in your stomach when a doctor recommends yet another medical test for your elderly parent or loved one? That worry that creeps in when you wonder if all these tests are really necessary or if they might actually be causing more harm than good? I've seen this concern countless times in the families I've worked with. Just last month, Eleanor, a vibrant 78-year-old woman, came to me after her 5th CT scan in 2 years. She was exhausted, worried, and her body was starting to show signs of breaking down, not from her original condition, but from all the testing and procedures. What her previous doctors never told her was that some of these common tests, the very ones we trust to keep us safe, can actually increase cancer risk and create other health problems, especially in seniors whose bodies are more vulnerable. Today I'm going to reveal the 7 medical tests that leading physicians are now warning about, tests that could be unnecessarily harming the seniors you love and potentially even triggering cancer. And most importantly, I'll share what alternatives you can discuss with your doctor instead. This information could quite literally be life-saving, so please stay with me until the end, because the last test I'll discuss is one that nearly 70% of seniors undergo repeatedly, often with zero benefit and significant risk. Hey there, thanks for joining me today on this critical topic. I'd love to know where you're watching from, so drop your location in the comments below. If you have questions about specific tests or medical procedures for seniors, feel free to ask in the comments section, and I'll do my best to address them in future videos. If you're new here and care about protecting the health of seniors in your life, especially when it comes to cancer prevention and treatment, hit that subscribe button and turn on notifications so you never miss potentially life-saving information like what I'm about to share today. Before I dive into the first problematic test, I need to pause and ask you something important. What medical tests or procedures have you or your elderly loved ones found most concerning or uncomfortable? What experiences have made you question if a test was really necessary? You know, many people feel alone in questioning medical advice, as if doubting a doctor's recommendation somehow makes them irresponsible. But I want you to know that being an advocate for yourself or your loved one is one of the most responsible things you can do. Understanding the risks and benefits of every procedure is your right, not an imposition on the healthcare system. If you'd like to share your experience, you can simply copy "My concern with medical testing has been," and complete it with your thoughts. Even a brief comment can make a difference. Your insights not only help me create more relevant content that addresses real concerns, but they also help build our community of informed caregivers and patients. Sometimes simply knowing others share your concerns can provide tremendous relief and validation during an otherwise overwhelming healthcare journey. Now let's talk about the first test that doctors are increasingly concerned about for seniors: repeated CT scans. Computed tomography or CT scans have revolutionized medicine by allowing doctors to see inside the body in extraordinary detail without surgery. They've saved countless lives by helping diagnose everything from tumors to blood clots. But here's what many doctors won't tell you unless you specifically ask. A single CT scan of the chest exposes you to roughly 70 times the radiation of a standard chest X-ray. For seniors who often receive multiple scans to monitor chronic conditions, this radiation exposure adds up significantly over time. Studies published in the New England Journal of Medicine estimate that radiation from CT scans may contribute to up to 2% of all cancers in the United States. This risk is particularly concerning for elderly patients whose cells already have accumulated damage over decades of life, making them more susceptible to radiation-induced mutations. The problem has become so significant that the American College of Radiology now has specific guidelines about the frequency of CT scans, yet these guidelines are frequently overlooked in clinical practice. Have you ever wondered why the technician steps behind a protective wall when performing the scan while the patient lies exposed to the radiation? That's because they understand the cumulative risk of repeated exposure. For elderly patients in particular, the risk becomes even more pronounced because their bodies are less efficient at repairing cellular damage from radiation. A 2019 study in the Journal of the American Geriatric Society found that patients over 70 who underwent 3 or more CT scans within a 5-year period had a measurably increased risk of developing leukemia and other cancers compared to age-matched controls who didn't have these scans. The truth is, many CT scans ordered for seniors are follow-ups that don't actually change the treatment plan. Dr. Rebecca Smith-Bindman, a radiology professor at UCSF Medical Center, has found that up to 30% of CT scans performed on elderly patients could be replaced with lower radiation alternatives or avoided altogether without negative impacts on patient care. What makes this especially troubling is that many seniors with chronic conditions often see multiple specialists, each ordering their own imaging studies without coordinating with other providers, leading to unnecessary duplication of high radiation tests. If you or a loved one has a condition requiring monitoring, ask your doctor about alternatives like ultrasound or MRI for follow-up imaging when appropriate. While these alternatives may not always be suitable, they don't use ionizing radiation and therefore don't carry the same cancer risk. Also, always bring a complete list of previous imaging studies to each doctor appointment, including dates and locations. This simple step can prevent duplicate testing. And perhaps most importantly, always ask this crucial question: how will the results of this CT scan change my treatment plan? If the answer is vague or unsatisfying, consider seeking a second opinion before proceeding with another high-radiation test. Remember, good medical care for seniors isn't about doing every possible test, but about doing the right tests at the right time for the right reasons. The second concerning test that deserves scrutiny is routine chest X-rays during annual physicals or hospital admissions. You might be surprised to learn that many hospitals still include chest X-rays as part of standard admission protocols for elderly patients, even when they show no respiratory symptoms. Similarly, some primary care physicians include them in yearly checkups, often out of habit rather than evidence-based necessity. While a single chest X-ray delivers much less radiation than a CT scan, the cumulative effect of yearly or even more frequent X-rays adds up over time, especially for seniors whose DNA repair mechanisms aren't as robust as those of younger people. The American College of Physicians has explicitly recommended against routine chest X-rays in asymptomatic individuals, stating they provide no mortality benefit and can lead to false positives that trigger even more testing, creating a cascade of unnecessary procedures. Despite these recommendations, a study in JAMA Internal Medicine found that over 40% of elderly patients still receive routine chest X-rays during annual exams or hospital stays without clinical indications. So why does this practice persist? Part of the answer lies in defensive medicine, where doctors order tests partly to protect themselves from potential lawsuits. Another factor is patient expectation, the belief that more testing equals better care. But for elderly patients in particular, this approach can backfire. False positive findings on routine X-rays are common in older adults due to age-related changes that can mimic disease. These false alarms frequently lead to anxiety, additional testing, and sometimes invasive procedures for conditions that would never have caused symptoms or reduced quality of life. A classic example is the incidental finding of a small lung nodule in an 85-year-old patient during a routine X-ray. This discovery often triggers follow-up CT scans, perhaps a PET scan, and sometimes even a biopsy, all carrying their own risks. Yet studies show that in patients over 80, the vast majority of small incidental nodules are benign, and even when malignant, are often slow-growing cancers that would never become symptomatic during the patient's natural lifespan. Have you ever stopped to consider that sometimes the kindest medical care means doing less rather than more? Instead of routine chest X-rays, doctors should perform thorough physical exams and order imaging studies only when specific symptoms or risk factors warrant them. If you're caring for an elderly loved one, always question whether a proposed chest X-ray is being ordered because of specific symptoms or concerns, or simply as part of a routine battery of tests. If it's the latter, a respectful conversation about risks versus benefits is entirely appropriate. Remember that good geriatric care often means being selective about testing and focusing on interventions that improve quality of life rather than simply gathering data that won't change management. The third test raising red flags among geriatric specialists is contrast-enhanced CT scans, particularly for patients with compromised kidney function, which is common in the elderly. The iodine-based contrast agents used to improve visualization in CT scans can be problematic for seniors for several reasons. First, and most seriously, these contrast materials can cause contrast-induced nephropathy, a form of kidney injury that occurs within 48 hours of receiving contrast. For elderly patients who often already have some degree of kidney impairment, this additional insult can tip them into acute kidney failure requiring dialysis, with mortality rates as high as 20% in severely affected individuals. What's particularly troubling is that studies suggest up to 30% of contrast CT scans in elderly patients may be performed without checking kidney function beforehand and without adequate hydration protocols to protect the kidneys. Beyond kidney concerns, contrast agents can trigger allergic reactions ranging from mild rashes to life-threatening anaphylaxis. While severe reactions are relatively rare, occurring in about 0.04% of cases, they're more common and potentially more dangerous in elderly patients who may be taking multiple medications that complicate treatment of these reactions. What many patients don't realize is that contrast material doesn't just wash out of the body immediately after the test. Some components of these agents can be retained in the brain, bones, and other tissues for months or even years, with still unknown long-term consequences. Recent research has identified gadolinium deposits in the brains of patients who've undergone contrast-enhanced MRIs, raising similar concerns about iodine-based CT contrast agents. For elderly cancer patients who often undergo numerous contrast-enhanced scans to monitor their disease, this cumulative exposure becomes particularly concerning. Have you or a loved one ever experienced side effects after a contrast CT that weren't fully explained beforehand? The good news is that for many conditions, non-contrast CT scans can provide sufficient information for diagnosis and treatment planning. Advances in CT technology have improved image quality to the point where contrast is often unnecessary for many applications. Additionally, newer contrast agents with better safety profiles are being developed, though they're not yet universally available. If a contrast CT is truly necessary, make sure the ordering physician is aware of any kidney issues and ask about pre-procedure protocols like IV fluids that can reduce kidney injury risk. Also ensure that the lowest possible dose of contrast is used, as many facilities routinely use standard doses rather than weight-adjusted amounts that might be more appropriate for smaller elderly patients. And always question whether previous scans might provide the necessary information without subjecting your loved one to another contrast exposure. The fourth test that deserves careful consideration is screening mammography in very elderly women. Now, let me be absolutely clear. Mammography has saved countless lives through early detection of breast cancer. However, its risk-benefit ratio changes significantly with advancing age, especially past 75. Despite this changing equation, many women in their 80s and even 90s continue to undergo annual mammograms without a discussion of whether this screening remains beneficial at their age. The U.S. Preventive Services Task Force doesn't recommend routine mammography for women over 75 because there's insufficient evidence that the benefits outweigh the harms in this age group. Yet a Medicare claims analysis published in JAMA Internal Medicine found that over 50% of women over 80 were still receiving regular mammograms, often continuing the same screening schedule they followed in their 50s and 60s. Why is this concerning? First, breast tissue in elderly women contains more fat and less dense glandular tissue, making cancers generally easier to feel during clinical breast exams. This means that dangerous, fast-growing cancers are more likely to be detected through physical examination, between screening mammograms anyway. Second, As women age, particularly past 80, they're far more likely to die from other causes before a slow-growing breast cancer would ever become symptomatic or life-threatening. Studies show that it takes an average of 10 years for the mortality benefits of mammography to be realized, meaning screening is unlikely to extend life for women with less than a 10-year life expectancy. Third, false positives and overdiagnosis become increasingly problematic with age. The detection of small, non-threatening cancers that would never cause symptoms leads to unnecessary anxiety, biopsies, surgeries, radiation, and even chemotherapy, all of which carry greater risks in elderly patients. I've seen 87-year-old women with multiple serious health conditions endure the physical and emotional trauma of breast cancer treatment for tiny, low-grade tumors that almost certainly would never have affected their quality or length of life. Has your doctor ever discussed stopping cancer screening as you or your loved one has aged? Most haven't, because these conversations are difficult and time-consuming, but they're essential. Instead of automatic annual mammograms, women over 75 should have individualized screening decisions based on their overall health status, life expectancy, and personal preferences. A healthy, active 80-year-old with longevity in her family might reasonably choose to continue screening, while a 75-year-old with heart failure and dementia would likely experience only the harms of mammography with none of the potential benefits. If you're caring for an elderly woman, encourage an honest conversation with her doctor about whether continued mammography aligns with her values and overall health goals. Remember, good preventive care isn't about doing every possible screening test, but about doing those tests that offer a favorable balance of benefits to harms for each individual. The fifth test that geriatric specialists are increasingly questioning is prostate-specific antigen or PSA screening in elderly men. This blood test, which measures a protein produced by the prostate gland, has been controversial even for younger men, but for seniors over 70, the evidence increasingly suggests that risks outweigh benefits in most cases. The American Urological Association and the U.S. Preventive Services Task Force both recommend against PSA screening in men over 70, and the American Cancer Society suggests that men with less than a 10-year life expectancy should not be screened. Yet studies show that up to 40% of men in their 80s still regularly receive PSA tests, often without discussions about the potential harms. What makes PSA testing particularly problematic for elderly men? First, PSA levels naturally increase with age, leading to more false positives that trigger unnecessary biopsies. These biopsies aren't benign procedures. They carry risks of bleeding, infection, and pain that are greater in older men. In fact, hospitalization rates for biopsy complications are nearly 3 times higher in men over 75 compared to those under 65. Second, and perhaps most importantly, prostate cancer in elderly men is typically slow-growing. Autopsy studies have found that more than 50% of men over 80 have prostate cancer, yet the vast majority die with these cancers, not because of them. By screening elderly men, we often detect cancers that would never have caused symptoms during their lifetime. The real tragedy occurs when these non-threatening cancers are treated with surgery, radiation, or hormone therapy, all of which can significantly reduce quality of life through side effects like incontinence, erectile dysfunction, and bone loss. I've counseled countless families dealing with the aftermath of prostate cancer treatments in very elderly men, treatments that offered little chance of extending life, but certainly diminished its quality in the final years. Have you ever considered that sometimes intensive medical intervention can actually steal precious quality time from seniors rather than adding meaningful years? This isn't to say that PSA testing is never appropriate for older men. Those with high risk factors, family history, or African American heritage might still benefit from selective screening up to age 75 if they're otherwise healthy. But for most men over 70, particularly those with other health conditions, routine PSA screening likely causes more harm than good. If your elderly father or grandfather is still getting regular PSA tests, initiate a conversation with his doctor about whether this screening truly aligns with his overall health goals and life expectancy. Ask specifically, is he more likely to die from prostate cancer or with prostate cancer? The answer to this question should guide screening decisions. Remember that respecting our seniors sometimes means protecting them from unnecessary medical interventions, not just ensuring they receive every possible test. The sixth test that requires careful consideration in elderly patients is colonoscopy, particularly as a screening tool in very advanced age or for those with significant health limitations. Colonoscopy has undoubtedly been one of medicine's success stories for reducing colorectal cancer deaths through both early detection and removal of precancerous polyps. However, its risk-benefit profile changes dramatically with advancing age and declining health status. Current guidelines from the U.S. Preventive Services Task Force recommend against routine colonoscopy screening in adults over 75 and suggest individualized decisions for those between 76 and 85 based on overall health and prior screening history. Yet many elderly individuals continue to undergo colonoscopies well into their 80s and even 90s without adequate discussion of whether the potential benefits justify the risks at their age. The prep alone for colonoscopy, which typically involves consuming large volumes of strong laxatives and clear liquids, can be physically taxing and potentially dangerous for frail elderly patients. Dehydration, electrolyte imbalances, and kidney injury are not uncommon complications of colonoscopy preparation in seniors, sometimes requiring hospitalization before the procedure even takes place. During the procedure itself, elderly patients face increased risks from sedation, including respiratory depression, aspiration, and cardiac events. The colonoscopy procedure also carries risks of perforation, bleeding, and infection that increase with age. While these serious complications are relatively rare, occurring in less than 1% of cases, their frequency and severity increase significantly in patients over 80. Even more concerning is that when complications do occur in very elderly patients, they're more likely to be life-threatening or permanently debilitating. But perhaps the most important consideration is whether colonoscopy findings will actually benefit the patient, given their life expectancy. Colorectal cancer typically develops slowly, with most polyps taking 7 to 10 years to progress to cancer. For patients with less than a 10-year life expectancy due to age or other health conditions, detecting and removing polyps is unlikely to provide any mortality benefit, while still exposing them to all the procedure's risks. Have you or your loved ones ever declined a recommended medical test? How did your doctor respond? I've observed that many physicians continue to recommend screening colonoscopies for very elderly patients largely out of habit or fear of missing something, without fully considering whether findings would truly benefit the patient at this stage of life. For seniors between 75 and 85, colonoscopy decisions should be highly individualized, taking into account not just age but overall health status, prior screening history, and personal preferences. Those who've had normal colonoscopies in their 60s or early 70s and no new symptoms generally don't need additional screening. For those over 85, routine screening colonoscopy rarely offers benefits that outweigh risks. If there's concern about colorectal cancer in elderly patients who aren't candidates for invasive screening, less risky alternatives exist. Annual high-sensitivity fecal immunochemical tests, FIT, can detect cancer with reasonable accuracy without the physical stress of colonoscopy preparation or procedural risks. These tests look for hidden blood in the stool, which can be an early sign of colorectal cancer. Remember that good geriatric care means carefully weighing potential benefits against risks and burdens, always keeping quality of life at the forefront of decision-making. The seventh and final test that deserves special scrutiny for elderly patients is perhaps the most common: routine blood work, particularly comprehensive metabolic panels and complete blood counts ordered without specific clinical indications. Now you might be thinking, how could a simple blood test possibly be harmful? The blood draw itself is minimally invasive, though elderly patients with fragile veins may experience more pain, bruising, or multiple stick attempts than younger patients. But the real concerns lie in what happens after the results come back. Older adults naturally have more laboratory abnormalities than younger people, even when they're perfectly healthy. A study in the Journal of the American Geriatric Society found that more than 75% of adults over 80 have at least one laboratory value outside the normal range when tested with comprehensive panels, despite having no symptoms related to these abnormalities. These minor deviations from textbook normal values, which often represent normal aging rather than disease, frequently trigger cascades of unnecessary further testing, specialist referrals, and sometimes even harmful treatments. Consider Mrs. Johnson, an 86-year-old patient I worked with who came for a routine visit feeling well. Her doctor ordered a comprehensive metabolic panel just to check, even though she had no new symptoms. The results showed a slightly elevated alkaline phosphatase, a liver enzyme. This triggered an ultrasound which found a tiny cyst on her liver, which led to a CT scan, which found an indeterminate nodule in her lung, which led to a PT scan, a bronchoscopy, and ultimately a surgical lung biopsy, which found nothing but normal age-related changes. Mrs. Johnson spent 6 months anxious about a potential cancer diagnosis, underwent multiple invasive procedures, and developed a post-surgical infection requiring a 2-week hospitalization, all stemming from a blood test she never actually needed. The problem is particularly acute for elderly patients, seeing multiple specialists, each ordering their own blood work without coordinating with other providers. I've seen seniors undergo identical blood tests 3 times in a single week, because a primary care physician, cardiologist, and nephrologist each ordered the same panels without checking what the others had done. This not only wastes healthcare resources, but subjects vulnerable elderly patients to repeated needle sticks and potential harm from follow-up cascades. The American Geriatric Society, through its Choosing Wisely campaign, now specifically recommends against ordering routine lab tests at regular intervals rather than in response to specific clinical questions. Yet the practice remains extremely common, driven by habit, misguided thoroughness, and sometimes financial incentives in fee-for-service systems. Have you ever wondered why your doctor orders the same battery of tests year after year even when you're feeling well? Next time, try asking this simple question: how will the results of these tests change my treatment or improve my quality of life? If the answer isn't clear and compelling, it might be reasonable to question whether the testing is truly necessary. Of course, targeted blood tests based on specific symptoms or to monitor known conditions remain essential tools in geriatric care. The key distinction is between thoughtful, targeted testing and reflexive, routine panels that are more likely to detect meaningless abnormalities than to identify clinically important problems. When laboratory testing is necessary, request the minimum testing needed to answer the specific clinical question, rather than broad panels that screen for dozens of potential abnormalities. This approach, sometimes called minimally disruptive medicine, aims to reduce the burden of healthcare itself on elderly patients' quality of life. So what can you do with all this? Information to protect yourself or the seniors you love. First and most importantly, be an engaged partner in medical decision-making. Question the necessity of tests, especially when they're presented as routine rather than responding to specific symptoms or risk factors. Always ask how the results will change treatment plans or improve quality of life. Second, keep a complete medical record, including all tests performed, when and where. This simple step can prevent duplicate testing and help doctors see patterns over time rather than reacting to isolated results. Third, consider seeking care from physicians who specialize in geriatric medicine when possible. These doctors have specific training in the unique aspects of caring for elderly patients and tend to be more judicious in their testing approaches. Fourth, remember that the goal of medical care changes with advancing age and declining health. For a 40-year-old, detecting every possible abnormality might make sense. For an 85-year-old with multiple chronic conditions, preserving function, independence, and quality of life often becomes more important than diagnosing and treating asymptomatic conditions that would never cause problems in their remaining lifespan. Finally, and perhaps most critically, have honest conversations about goals of care. What matters most to you or your elderly loved one in the time that remains? Is it maximizing years of life at any cost in terms of discomfort and medicalization? Or is it maximizing quality of life, comfort and autonomy, even if that might mean accepting some medical uncertainty? There are no universally right answers to these questions, but asking them can help guide decisions about testing in ways that align with deeply held values and priorities. Thank you so much for staying with me throughout this important discussion. I hope the information I've shared today helps you become a more informed advocate for yourself or the seniors you care about. Remember that good healthcare isn't about doing more. It's about doing what's right for each individual. If this video has been helpful to you, please give it a thumbs up and share it with others who might benefit from this information. Your experiences matter tremendously, so I encourage you to leave a comment about your own healthcare journeys or questions you might have. And if you haven't already, please subscribe to our channel and turn on notifications so you don't miss our upcoming videos on protecting senior health and navigating cancer care. Together we can create a community of informed advocates working to ensure that medical care for our elders truly serves their needs and honors their dignity. Remember, the most powerful medicine often isn't found in a pill bottle or a high-tech scanner, but in the courage to ask good questions and the wisdom to know when less intervention might actually be more healing. Until next time, wishing you and your loved ones the very best in health and well-being.